now my hard part is to get it to move. There we go. So basically, we're asking ourselves two questions anytime we have a patient who's not doing well. Our first question when we talk about emergency access is, do we have access? And if we have access and it's working, then we can handle the emergency right there and then. Yes, we might want a second access or even a third access, but if we have something that's working, we can get drugs to our patients quickly. And so this is not talking about that child who has a working access. So the second question we're going to ask is, how sick is your patient? Well, to answer that, we put together this very convoluted, very busy slide that you're seeing that asks basically four questions to get to how bad do I need access and what is the best mode of obtaining that access in my patient within a 3-minute time frame. Now, like I said, if you have access in place, you've already met the goal. So these are kids without access. So the first question is, how sick is your patient? And if you answer the question, really darn sick, he's obtunded, he's hypotensive, or he's in cardiac arrest. Now, this is a patient that you need access fast. And this is also a patient that if you tried to get a peripheral line, you will not be successful. These are kids that are clamped down. They have no good distal pulses. They're not getting blood to their fingers, hands, feet. And so it really doesn't make sense to waste your time with peripheral sticks. And so with these kids, we're going to go straight to the interosseous needle because that'll be our quickest way that we can get drugs to our patients. So the next thing we ask is, okay, well, my patient is sick. He's not dying yet, but he could if we don't do something quickly. And these are kids that have a GCS of 4 to 8. So they're not protecting their airway. Their respiratory failure, they may be bradycardic. They have low SATs despite high flow oxygen. And so these are kids that our answer is going to be, they are going to need drugs pretty quick. Again, you might be able to get an IV depending on how clamped down, but we don't want to just wait for that IV to be placed. So simultaneously, we're going to go ahead and drill for an IO access or put in an IV. Now, some of you at this point may be asking, well, what about a central line? Central lines are great. The reason they're really not built into this algorithm is because we really frown upon central lines being put in the code bay, not considered the cleanest room in the hospital. And even if you're in the ICU, you know, a central line does take some time to put in. And so it may not be able to give you that first access as quickly as you want it. So, okay, the next question we ask is, if our patient's not in respiratory distress, their GCS is at least 9 or above, the next thing we're going to say is, my patient is sick, but he's compensating. So signs of compensation is tachycardia, maybe some tachypnea. O2 sats are maybe less than 94, but you're on just, you know, a liter or two, and they're not too low. These are kids that you have a little bit of time. They're probably not terribly clamped down, although they could be. But you have a little bit of time to get that IV. And so these are kids that we say, yes, it's pretty emergent that we get an IV, but we can do it over a 3-minute period of time, usually no more than 3 sticks. And, you know, I say that 3 minutes, that 3 minutes is not an absolute, but what we don't want to do is with a patient that's in compensated shock, we don't want to be wasting a whole lot of time, and we definitely don't want to be torturing this child with, you know, 6 different nurses all taking three attempts and not having success. So in these kids that are in compensated shock, one solution is you can go to an IO. People tend to frown on that or not feel great about that because your kid is awake and talking and they're thinking, well, this is pretty painful. Just so you know, the IO is not necessarily a comfortable experience. But when the IO drill was new, I actually saw the designer of it at a conference, and he was drilling into his own leg while he was awake, and offered to drill into anybody's leg if we wanted them to. I chose not to take part in that. So it's probably not near as bad as what we might think it is. With these patients, if we do decide to go that peripheral IV route, we really need to go with that experienced person, somebody on your floor, somebody that you know is good, maybe call the IV team, because they are going to be a difficult stick. And then, of course, here's where we can consider those other resources. Here we do have time if a central access is the thought of choice from the medical team. And then finally, with this algorithm, when we get to the last question is, well, my patient is stable, but they need antibiotics, they need pain meds, or maybe even contrast for CT. So these are patients that are not tachycardic. These are pretty stable patients that should be more on the easier side of IV placement. And so again, we say IV placement, 3 attempts over 3 minutes. Again, that 3 minutes is not an absolute, but it's to really save us from torturing those children before we contact IV team or some other resource to figure out how to get access. And then maybe they don't need any meds. They don't need antibiotics. We're managing with oral pain meds. They don't need contrast for CT. We're not going down to MRI. Maybe we just need labs. And for those patients, we can forego that IV attempt and just go straight to phlebotomy. And so this is something we have been working on in the trauma department over the last year as we're really trying to become really more efficient in our ICU patients. And so I'm going to take questions on that before I move on to massive blood transfusion. Cindy, is there anything you want to do question-wise? Sorry.
We do not have any questions in the chat as of yet.
Okay, perfect. If they are, we can do them at the end of this.
Okay, that sounds great.
Let me get this one geared up. And so many screens going on here. Okay, is that the right screen?
Yeah.
All right, so next, I'm going to talk a little bit about massive blood transfusion protocol. Massive blood transfusion protocol basically all started with trauma, specifically in the military. I remember early in my career, and we won't talk about how many years ago that was, you gave blood, you gave platelets, you gave cryo, but there was really no rhyme or reason how we gave it, the composition, what we gave. And then the military started really looking at the fact that we use component therapy and how to take the components we use, meaning your red cells, your platelets, your FFP, your cryo, and how to put it back together to mimic what you get with whole blood. And so we know traumatic injury is one type of injury or one type of diagnosis in which our patients are losing whole blood. So what we're doing with massive blood transfusion is we're trying to remimic putting that whole blood back together. Because the replacement really does need to be all the components in what we're looking at. Because if we just give packed red blood cells, now we start diluting out all of our clotting factor and our patients become very coagulopathic, and you have a lot of that oozy bleeding that can happen. And when we don't have good clotting factor, we're going to have an increase in hemorrhagic mortality with our patients. Now, FFP is great and it's a great volume expander. And if your H&H is okay, a lot of times we'll give FFP as a volume expander, but it also has a lot of coag properties. When I give a lot of FFP or even 1 or 2 units of FFP, I'm going to dilute out all my hemoglobin. So now I have volume within my vessels, but my tissues become hypoxic. And so we really have to make sure we're giving these at good ratios. And so there were several military studies that were out there that have been looked at to design how we do massive blood transfusion. And so several studies you can see on here, they looked at FFP to RBC ratio, FFP 1 unit to 8 units of packed cells, and we still had a 92.5 hemorrhagic mortality rate with an overall mortality of 65%, which is not great. But you can see as you get closer in proximity to 1-to-1 transfusion, if you go to the bottom here, for 1 unit of FFP per 1.4 units of packed red blood cells, now your overall mortality is 19%, and your hemorrhagic mortality is 37%. And that's really where we want our patients to be. Now, we decided to launch massive blood transfusion at Children's National, really based upon our trauma verification. Back in 2000, like 10, 9 or 10, the new Orange Book came out, which is our trauma Bible. And that's what said that all trauma centers had to have a massive transfusion protocol. We knew this was coming up. And so we had already started working with Blood Bank to design what you now know as a massive transfusion protocol, and that we'll talk about today. Now, one of the hard things about massive transfusion protocols is there's no universal definition of this. So what we use as the definition for when to launch a massive transfusion is if a patient has clinical massive hemorrhage that's hard to control. And that's really why most of our MBPTs are launched, because the other definitions are a little bit harder to quantify. And that's ongoing blood loss of greater than 150 mils per minute, loss of more than a half of estimated blood volume in 2 hours. So basically, what we're saying is if you have a lot of bleeding, we can't stop it. MBTP is where you want to go. Now, the funny thing is that this was launched, and the premise behind why we have this in trauma is, or have this here at Children's, is for trauma. But what we find is the CICU uses it probably more than anybody on your regular patients, but also for patients that are requiring ECMO. The OR has used it several times when they have cases with unplanned bleeding. And our PICU is using it a lot of times for hemonc patients, for GI bleeds, and for other patients that become unstable due to blood loss. Now, activating massive blood transfusion. So you're on your unit, you're told to activate the massive blood transfusion. Well, it all starts with a phone call. This phone call, there's a hotline to the blood bank. It's a massive blood transfusion hotline, and that number is 5656. It's on all of the massive blood transfusion paperwork. I can only speak for the emergency department, but it is with the NAL stuff, and it is on the blood fridge. And so we know how to activate that fast. When you call 5656, basically you need to tell them that you're activating MBTP. They will ask if it's an ECMO prime. We will provide the name, MRN, weight, age, and gender of our patient. Weight and age and gender are actually very important because that's going to help the blood bank figure out the volumes that you need. And there, if you have a newborn or an infant, they're not going to be sending you the same volume as they would send you for a 12-year-old. And gender is going to be important because of RH status. A male patient can definitely get positive blood, where a female patient, they try to keep all packed cells negative. They'll ask you your location, and then they need a physician name and contact number because a physician does have to sign this order. There are some cheat sheets in the PICU, the CICU, the ED, and the OR that basically it's your massive blood transfusion packet. And this is going to give you some administration reminders as far as filters, what can go on the hotline or rapid infuser, what can't, what products we can give IV push. It'll also list the labs you need and what tubes that they need to go in. And so it's a nice cheat sheet to have in front of you. Now, we've learned that when you launch a massive blood transfusion, one of the secrets to success is identifying who is going to be the MBTP leader, who is going to make sure that they're the conductor over the orchestra. So these are the person that knows about the order set that's in Cerner. There is a massive blood transfusion order set. You're going to pull that up and you're going to launch that order set. You have the cheat sheet that lets you know the labs that are needed. Some patients that are on the inpatient side, those labs may be already in the system and they're okay, but patients coming in the emergency department will definitely need a type and cross, coags, and chemistries. You'll put together the pickup paperwork. That's the paperwork you're going to need to give to the transporter who is going to go pick up the blood in blood bank. That is part of the MBT packet. It's also available online. You'll assist with some of the blood verification, checking each unit, and you'll help track management of that massive blood transfusion. How many red cells are ordered? What pack are we in? And that's all stuff we'll discuss here in a minute. And then finally, that leader is in charge of calling the blood bank to tell them that massive blood transfusion is done, or that the patient is being transferred to a different unit. For instance, if you're in the code room in the emergency department, it's not uncommon for us to start massive blood transfusion down in the code room, but then send the patient to the OR or the PICU. And we'll send with the cooler that we're currently working with and call the blood bank and let them know where that patient now is. Now, as far as paperwork, there are 2 refrigerators that have O negative blood in the hospital outside of the blood bank. One is in the code room in the emergency department, the other's in the CICU. And that refrigerator is shared between the CICU and the PICU. If you're taking blood out of that refrigerator, it is so, so important to make sure that the paperwork that's with each unit of blood is completed. Specifically, that you have an MD signature on that order page, that paper order page. And then there's the blood release page. And both of those need to go to the blood bank. Failure to get those MD signature puts us at risk for losing these blood refrigerators, because we need to make sure that this is very controlled through all the regulatory agencies that the blood bank is being reviewed by. And just if you don't know, the blood bank is probably reviewed by more outside agencies than any other place in the hospital. I feel like they're constantly being checked on by somebody to make sure that we're following the right policies, procedures, and practices. And then, of course, the paperwork is that blood pickup request that you'll send with your transporter. Now, when we do activate massive blood transfusion, there's 3 packs that your patient will be getting. And it's basically what's going to come to you in the cooler and what the blood bank is going to be working on next. And the goal of this, remember, is to do that 1-to-1-to-1 therapy, meaning for every unit of red cells, you get a unit of FFP and a unit of either platelets or cryoprecipitate. So your pack A right now is just red cells. We're going to use those red cells. They'll help increase volume in your patient if you're volume depleted, but they're also going to increase your hemoglobin, which will at turn increase your ability to have tissue oxygenation. And your child with who's in shock, this is going to be incredibly important to make sure we can get oxygen to every place that needs it. If you're using emergency release or O negative, if there is no active type and cross in the system, so all your ED patients and even your PICU-SICU patients, check and see how old your type and cross is. If it is not current, you'll use the O negative and send another type and cross. If you have an active type and cross, you could alert the blood bank. You may still want to start with 1 unit of O negative until blood bank can then get you type specific blood to your unit. You do require a transporter in order to get anything from the blood bank. Now, while you're giving pack A, whoever's the leader has put the order in for massive blood transfusion. They're filling out the paperwork. They've called the blood bank. So the blood bank now immediately gets working on pack B. Pack B contains FFP platelets and more packed red blood cells. Now, again, we want those packed red blood cells because we want to continue that regeneration of hemoglobin. But we don't want to give just packed red cells because remember, we'll get coagulopathic. And so a lot of times when my pack B gets here, the first thing I take out of pack B is usually my FFP. My FFP is going to help restore some volume. It has fibrinogen in it. And so it's going to help us with clotting. And so I'll give my yellow products probably at the beginning of my pack B, followed by the packed red blood cells, because that's going to help me get that 1-to-1-to-1 ratio that I'm looking for. Now, over the past year, we actually had a big advancement with our massive blood transfusion protocol in that prior to this year, FFP was always frozen. And so it would take about 17 to 20 minutes to get a full pack B. The blood bank is now keeping thawed plasma in the blood bank, and so it's readily available. And so pack B should not be delayed like they had been in the past. Now, once you're using pack B, the blood bank is going to get ready making pack C for you. Pack C is pretty much the exact same thing as pack B, but instead of platelets, you're going to have cryo. And again, because I started with yellow on pack B, I start with yellow on pack C, and that's just my personal preference. It seems to make sense to me in order to keep that 1-to-1 ratio. But that's something that your team can discuss on a case-by-case basis. Now, remember that blood bank is going to continue to pull that next pack until we tell them to stop. So as soon as our patient is stable and we can stop massive blood transfusion, it really is important for the blood bank to know about that because we want to minimize waste. So we've given A, we've given B, we've given C. What do we do now? We keep repeating B and C packs until the event is over. I spoke a little about labs. Whenever we launch a massive blood transfusion, there's labs that have to be sent. If we don't have an active type and cross, we're going to send an active type and cross. We'll start with the O negative cells until we have type specific, of the ability to give type specific. Everybody who has a massive blood transfusion, within the early stages of that, we should be attempting to send a CBC, coags, BMP, and a blood gas. And within the guidelines, I believe every time we give PAC-C, we probably are going to repeat your coags and your blood gas. Now, will a physician ever deviate from giving PAC-A, PAC-B, PAC-C? Absolutely. Some things are going to happen, and you're going to have a physician that says, wait a minute, we don't need any more red cells. We're just going to go yellow. Now, that may, a lot of times that's going to be based on some of the labs that come back. Maybe you have labs that come back that show you have a crit that's pushing 40. Well, if you have a crit that's pushing 40, we don't want to push that crit too high, because then you get blood sludge, and it's really not necessary. And so that's when we'll use the FFP or the platelets as volume expanders and work on that coagulopathy. So I guess the biggest take home is that sometimes it is okay to deviate from how massive blood transfusion tells you. Now, once bleeding has stopped, we're going to call the blood bank, let them know that we're stopping massive blood transfusion. Remember, if you transfer a patient to a different area while massive blood transfusion is happening, we need to inform the blood bank of where the patient is going. If you're the nurse at the bedside when we start massive blood transfusion, you need to make sure we have working access and people in the room that are helping you know exactly what access you have. We're going to verify all of our blood product components. We'll be drawing the labs. I think probably the biggest thing to tell people is that after we use a bag of blood, FFP, platelets, cryo, retain those bags. Those need to go back to blood bank. And we're going to document our exact amount of every product we've given. It really is important in the chart that we can identify how much of each blood component that's been given at exactly what time. So when you document a massive blood transfusion, we need what time did it start, how much blood or volume you gave every hour. That needs to be subdivided by product, so I can tell we got so much, 500 of FFP and 300 of blood and 300 of platelets, and then I need a stop time. Now, I don't know if you've been watching the literature, but there's a lot of literature out there about whole blood and the use of whole blood in hospitals. Whole blood was something, that was done years and years ago prior to my entry into the medical field. Since I've been working for the last 30 years, it's always been component therapy. But now there's a lot of push to go back to whole blood. And in the adult trauma centers, we're seeing whole blood use actually quite a bit. The pediatric centers have started using whole blood, a handful, and there's some studies on that. Pittsburgh's been kind of leading the way. The benefit of using whole blood is we don't have to worry about one-to-one-to-one. Bag of whole blood comes down, we spike it, we infuse it. Life is good. They're getting oxygenate, they're getting oxygen carrying capacity with the through their hemoglobin. There's platelets, there's plasma in there. It's great. The hard part about whole blood, it's only good for about 4 to 5 days in the blood bank, where PAC cells are good for 30 days, and FFP frozen is good for a year. And the reason it's only good for 4 to 5 days, their platelets are usually all going to die out by day 5. So the longer a bag of whole blood sits, the less platelet component you're going to have. The other issue we find in pediatrics with whole blood is we have to watch the potassium level, because there's breakdown of cells because those platelet cells are dying off. And so we're really going to have to watch the potassium level pretty closely if we gave whole blood, to make sure that our patients aren't getting hyperkalemic. And I know in Pittsburgh, they can give, I believe every 2 units, they check a potassium level to make sure that their patients are okay. I tell you this because we are probably looking at entering a study where we may start seeing some whole blood use here at Children's. And so where we're not using it now, stay tuned. And the next time you talk to me, it may be because whole blood is coming to a hospital near you. With that, I'll open it up if anybody has any questions.
remember, I don't remember you saying this, but did you talk about like where our hospital gets blood? Because I always find that really interesting.
I did. It's very interesting because most of the blood that we use comes from our own blood donor center. One of the things I have to look at every 3 years when we do our trauma verification is how much blood do we keep, how much of each component are kept in our blood bank at all times. We are totally self-sufficient with FFP, and at any time we keep at least 600 units of FFP in the hospital at all times. So it's pretty amazing when you think that our blood donor center really keeps us that self-sufficient. And it's probably because we hear them advertised literally 3 times a day overhead.
It's crazy. How often do we do the massive blood transfusion, like in a year, like all units combined?
All units combined, it's almost once a month at least. And we actually, through the blood utilization group, we revisit and look at every single massive blood transfusion quarterly to look at how good we do, can we do better, where we're at. And like I said, probably the winner for most massive blood transfusions every year go to CICU, and it's because they've used it so much that we've actually become much, much better at it. So the CICU gets props to really looking at the process and how to streamline.
So we are early because I have you until noon. So while I have you on as a trauma program manager, talking to our new nursing staff, two children's, and we do have some people that have been here before. What do you think is the most important thing to know as a new nurse or even an older nurse in the trauma and burn department? What do you think is, you could tell everybody one thing that you never want them to forget?
Pay attention to compensated shock. Know what compensated shock looks like, know how to identify compensated shock, know what to do with compensated shock, and know how to escalate compensated shock. Tachycardia is never okay. Can I add one more thing to that?
Oh, you got
If I have
14
a
minutes.
second?
You can talk. You can add as
I
much
can
as
just
you
talk
want.
away. It's funny when we talk about compensated shock, probably the 2 things that we see most in kids are a tachycardia and a decrease in distal perfusion. And the third thing that goes with it is altered mental status. And these are things that we look at kids and we can make lots of excuses for. We can say they're scared, they're anxious, mom's not here. But if you don't have good distal pulses and your patient is kind of losing their mind, it's probably not anxiety, it's probably lack of oxygen to the brain, because if you don't have good distal pulses, you are not getting oxygen to every place you need to be. And anytime we've had a trauma patient go bad and we've had a late rescue or been delayed getting the care we need, it's because we haven't recognized compensated shock when we needed to, and we let it go till it became uncompensated shock. So that would probably be my pearl. The other thing I would tell you is please make sure you always get your education hours, because every 3 years when we have to do our verification, we really love being able to show off just really how educated and on top of things that our nurses are. And we give you lots of opportunity and hope that you can take them because we enjoy doing it. We're hoping that we give you stuff that you can enjoy too. Sorry, Cindy, I actually shortened my talks thinking I was going to talk too long.
Oh, well, no worries. You know what, guys? So lunch isn't until 1, and our next speaker is at 12:10. So consider this like a pre-lunch. This is your appetizer. So feel free. I mean, I'm going to be here hanging out if you guys have any questions. And hold on one second. I'm going to stop the recording. So stop.